that. And then we are just about ready to go live on Facebook. So we will, Jen and I are going to go ahead and go off camera because I forgot to do that one time and it shows up on the Facebook and it's super weird. So we'll go ahead and go off camera. But like I said, we will be here in the background.
And you'll send us a chat message that we're live.
Yes,
Okay.
yes. So here, and it always takes like about 30 seconds for it to actually go live. So I'll try to time it up correctly, but we will see. But here in a second, you are going to see the live icon up in your top corner, close to where the recording cloud thing is. You are not live yet. If you see that, I will give you your cue in the chat.
Sapna, did you have any preference on what question we ask as the first one?
I don't. Do you want to go ahead and start, or do you want me to do the first one?
I'll do the first one.
Okay, sounds
and then
good.
well, we can alternate after that.
Sounds
so
great.
I think Ben, I may start with you, ask you about thyroid eye disease, if that's okay.
Sure.
Okay, cool.
This last minute or so always seems like a lifetime. All right, I'm going to go ahead and start the process. I'll give you your cue in the chat in just a second.
Good evening. We would like to welcome everyone to the Graves' Disease Awareness Month webinar hosted by the American Association of Endocrine Surgeons, or the AAES, and in partnership with the Graves' Disease and Thyroid Foundation. I am Dr. Stacy Woodruff, endocrine surgeon with the University of Hawaii John A. Burns School of Medicine and Queens Medical Center. And I'm one of tonight's moderators.
Hello, I'm Sapna Nagar, assistant professor in surgery and endocrine surgeon at Beaumont Hospitals in Royal Oak, Michigan. And I am one of the other moderators for tonight's webinar. We've assembled an expert panel to answer questions tonight about Graves' disease. The webinar tonight is being recorded and it will be available on the AAES Facebook page as well as the AAES YouTube channel. We would like to thank GTATF for providing us with frequently asked questions from their membership. We will also be taking live questions from the audience this evening. You can enter your questions in the comments section directly on the Facebook live stream. Please be aware that tonight we will not be answering any personal medical questions or providing specific medical advice. For those types of questions or requests, please seek advice from your doctor and medical team.
We will start by introducing and getting to know our panelists in alphabetical order. We will start with Dr. Sophie Dream. Please tell us a little bit about yourself and your background.
I'm Sophie Dream. I'm an endocrine surgeon here at Medical College of Wisconsin in Frederick in Milwaukee, Wisconsin. I did my training at Henry Ford Hospital in general surgery, and then went on to do my fellowship at University of Alabama, Birmingham. And then I've been here for just over 2 years now.
Thank you. And Dr. Benjamin Gigliotti.
Hi, my name is Ben Gigliotti. I'm an endocrinologist at the University of Rochester Medical Center, where I did undergrad, med school, residency, and then I did my fellowship at Massachusetts General Hospital with a focus in thyroid disorders. I rejoined the faculty at the U of R. We call it the Rochester Boomerang, where you come back to Rochester after some time away. And I'm currently a practicing thyroidologist and have been here for a little over 3 years.
Thank you. Dr. Jessica Gosnell.
Hi there and greetings, everyone. My name is Jess Gosnell. I am a professor of clinical surgery. I'm an endocrine surgeon at University of California, San Francisco. I'm a native Mainer, but I've been on the West Coast training for many years. I went to the University of Washington and then came down to UCSF. And then I did my endocrine surgery fellowship in Sydney, Australia. And then I've been at UCSF on faculty for about 15 years. So delighted to join all the other panelists and moderators.
Thank you. Dr. Christopher Mchenry.
Hi, I'm Chris Mchenry. I am a professor of surgery at Case Western Reserve University School of Medicine in Cleveland, Ohio. I'm also the vice chairman of surgery at Metro Health Medical Center in Cleveland, Ohio, where I've been in practice for 32 years. I did my general surgery training at Loyola University Medical Center, and then followed by a endocrine head and neck fellowship at the University of Toronto.
Thank you to our panelists for joining us tonight. We will start answering questions now. As a reminder, we will not be answering any personal medical questions or provide specific medical advice during the webinar today.
So our first question is for Dr. Gigliotti. After radiation, what is the risk of developing thyroid eye disease, and does it usually get any better?
And that's a great question. So thyroid eye disease occurs in maybe 20 to 25% of people who have hyperthyroidism, and it specifically is only seen in Graves' disease. So other causes of hyperthyroidism, such as toxic thyroid nodules, which develop a mutation that allows them to make too much hormone, or thyroiditis, these other conditions do not usually lead to eye disease. And there's a number of triggers that can lead people with Graves' disease to develop eye disease. Smoking is actually one of the major risk factors, and one that we often talk a lot about in clinic, because stopping smoking can have a huge effect in terms of making it less severe. And there's a number of other features in terms of having really high antibody levels from Graves' disease, which is an antibody-mediated disease where the thyroid gets short-wired and turned on. But radioactive iodine is also one of the potential triggers for that. So if maybe 20 to 25% of people have eye disease, a lot of people then, maybe 3/4 of them, do not have eye disease. And in the setting of radioactive iodine, up to 1/3 of people can develop eye disease, or if it was subtle or mild, develop worsening. And the idea is that radioactive iodine induces an inflammatory change in the thyroid, which can release a lot of the proteins that tends to fuel the immune system. And because the eye disease in Graves' disease is part of the immune system short wiring and causing inflammation and pressure behind the eyes, that increase in protein levels from the thyroid can worsen it. And usually we have very effective treatments, and it's an exciting time now because a new medication, teprotumumab, has been FDA approved, and is one that in the old days we often used steroids, and still do to this day in some cases, but this is a very exciting medicine that can help a lot of people.
Very good, thank you. I think we'll shift gears here a little bit and talk about the surgical options as treatment for Graves' disease. And maybe turn over the questioning to Dr. Dream. A patient asks, how do I know if thyroidectomy is the right treatment option for me?
Yeah, so that's definitely a big conversation to have with your endocrinologist and your endocrine surgeon. And you can go see your endocrine surgeon before you even have decided, and maybe don't end up getting surgery. I think that we're all open to having that discussion. It's really important to talk to the person that might be doing a thyroid surgery, whether or not you pursue that option. There's a lot of reasons why you would want to go that route. So if you need immediate control of your thyroid hormone and your thyroid hormone's really high, thyroidectomy is a really great way to get that immediate thyroid hormone level down. If you have really bad thyroid eye disease, radioactive iodine is not the best option. Patients that are looking to get pregnant within a year, we don't want to be giving those patients radioactive iodine, and thyroid surgery is really a really good option in those patients. And women that have young children, or men even that have young children, you don't really want to be around people that are going to be exposed to that radiation and have long-term outcomes that harm them. Other than that, so in terms of like when to get definitive treatment, radioactive iodine or thyroid surgery, really depends on the patient. So most people we know will go into remission after like that first year. And some people will be maintained on really low doses of methimazole, so like 5-10 milligrams. And in those people, I don't always push them to get definitive treatment. It's really when you start having side effects or all those negative consequences, a really difficult time controlling your thyroid or your Graves' disease and the consequences of that. And when we talk about doing either option.
Thank you.
Yeah.
Maybe we'll go to Dr. Mchenry. Can you talk about the parathyroids and how they're treated during thyroid surgery for Graves' disease?
Sure. So in general, you want to preserve the parathyroid glands in their normal anatomic position. We call that preserving the glands in situ. So you want to do your best to try to preserve the blood supply to those parathyroid glands. When you can't preserve the glands in situ, then we would do what we call parathyroid autotransplantation. And that is the gland is, particularly when you have a gland that's within the capsule of the thyroid gland that you've devascularized, or the parathyroid gland, you would remove it. And then you can send a little piece to your pathologist who confirms that it is parathyroid tissue. Then we mince those, the remainder of the gland, and then create a pocket, typically in the neck, in the what's called the sternocleidomastoid muscle, and then place that minced parathyroid gland in the pocket of the sternocleidomastoid muscle, and then close that with just a suture. And about 90% of those glands will function. So again, in summary, we try to preferentially preserve them in situ. When we can't, or devascularize them, or injure them, or remove them, we would auto-transplant them.
Thank you.
Dr. Gosnell, are you seeing more patients opting to have thyroidectomy as their definitive treatment or frontline treatment for Graves' disease? Or do you see more patients opting for thyroidectomy after they have failed radioactive iodine treatment? I guess this is sort of a bit of selection bias, because usually they're seeing you, they've already sort of gone through the process and talked about thyroidectomy as being a possibility. But in your experience, what have you seen?
Yeah, thanks for that question. I think it's actually relatively uncommon for me to have patients that have had radioactive iodine and we're doing surgery as kind of the remedial or the second treatment. But certainly I do see those patients. I think in general, most of the patients that I see have been medically managed for sometimes a year or 2 years, and either are continuing to not feel well and have symptoms, or are having some side effects from the medication, or they're just kind of looking for a more definitive option. So I'd say that's the majority of the patients that I see. I would also add, probably many of us see adolescents. And one of the reasons, just to add on to what Dr. Dream was mentioning, thyroidectomy can be a really nice option when time is kind of critical. You know, if you have someone in high school and they're on this kind of roller coaster with the medications, thyroidectomy can actually be a way to really treat them and kind of get them kind of back on course during those kind of critical years when they're in school.
Very good. Thank you. We have
Dr.
oh, sorry, I'm sorry. Go ahead, Stacy.
That's okay. We have a question from Facebook. Dr. Gigliotti, does vaping cannabis also lead to eye disease, or is it smoking nicotine?
So that's also a good question. So to my knowledge, all of the studies looking at the association between smoking and eye disease have looked at cigarette smoke specifically. And cigarette smoke has been shown through multiple mechanisms to increase the inflammation in the eye. But to my knowledge, I have not seen any studies showing marijuana smoke or anything related to marijuana or cannabis has any effect on thyroid eye disease.
Great, thank you.
We received a lot of questions with respect to the current COVID-19 pandemic and sort of how we are augmenting our practices and augmenting treatment algorithms to sort of accommodate what's been going on in the last 2 or 3 years. But Dr. Mchenry, can you shed some light on how this pandemic has affected the care of patients of Graves' disease, particularly in the practice of thyroid surgery?
Sure. I think that in general, most patients with Graves' disease, their operations have been during the height of the COVID, where our hospitals were really overrun with COVID patients. But most patients with Graves' disease, their operations were put on hold. Because in general, they require an overnight stay, and the beds and the problem with the protective equipment was a major issue. However, some of the other reasons we operate on patients with Graves' disease are when they have associated nodular thyroid disease, and there may be a concern for cancer, or in patients that have a really massive goiter and they have compressive symptoms. In those situations, we made exceptions and we operated on those patients, but those were the exceptions. And most patients we had to cancel and forego operations for patients with Graves' disease during the height of the COVID pandemic.
I will say for us, there were a good number of patients that we had a really hard time getting their hyperthyroidism under control. And in those cases, we did end up doing those operations, even if it was more elective than other cases, just because if that patient goes into thyroid storm, we're taking up an ICU bed and a lot more resources that way. So we're always weighing, like, on a case-to-case basis what the situation was, because we don't want to put people in bad situations in any situation, you know what I mean?
Yeah, I certainly think that during this entire time, the definition of elective has sort of changed a little bit. We've definitely had to question what we think an elective operation might be, and sort of go down these pathways about what somebody might need and make decisions that way.
Yeah.
I was just going to add, I think there probably, if you asked all of us, we've all had such different experiences in terms of the time in which the hospitals have been had to kind of partition care. So it's probably just moved all in different areas of the country at different times. But certainly, I think the question of electivity versus emergencies, we've all had to, spend time kind of thinking about that and discussing it, and probably coming up with kind of priorities,
right,
based on what was going on in our respective institutions.
If I could make one other comment, I can tell you this is it's happening again now. Yeah. Currently our hospital we're out of beds. Basically, we're at a peak of COVID patients. Our ICUs are full, and we're now have any operation that requires an overnight stay is not, unless it's urgent or it's a cancer patient, are being put on hold again. So this is happening again.
I was just going to add one other thing. We've been kind of talking about, kind of from our perspective, I think from patients, we might feel like, okay, we're ready. but many patients don't feel comfortable coming to the hospital for something that they think they could, temporize, which, I think that's very valid. It's also been, really challenging for people to have surgery with not the usual support staff. At our institutions, we're not having people in the preoperative area, so people are having to kind of go through this a little bit, a little bit more on their own. And I know that's been really challenging for people.
Yeah, it certainly has been a challenge getting through some of these peaks with COVID. Maybe sticking with our COVID theme, Dr. Gigliotti, can you talk a little bit about the risk of, maybe the risk of severe COVID-19 in patients who have Graves' disease, if there's any increased risk for them, and then any concern about the vaccine in patients who have Graves' disease?
Absolutely. So the two questions of the directionality, so COVID-19 and having Graves' disease and being at risk for more severe illness, is an important question. One study out of Denmark looked at over 16,000 patients and who had hypo or hyperthyroidism. So it wasn't just Graves' disease, but a mixture of different thyroid diseases. And they didn't see any increase in mortality in people with COVID-19 who had these various thyroid conditions. And in the folks who had Graves' disease, there didn't seem to be an increased risk of either severe illness or mortality or any of the complications of COVID-19. So as of right now, our current understanding is that while we always try to control the hyperthyroidism and control the thyroid, because we know severe hyperthyroidism in particular has a lot of symptoms that can overlap with COVID-19, which can be very confusing because of how many organ systems the thyroid can affect. I think it's just particularly important to know that this does not seem to be a particular risk factor. In terms of the vaccine, there's been a few case reports of Graves' disease occurring after the vaccine, but one of the most challenging things is many people go undiagnosed with Graves' disease for quite some time because of how many symptoms and how hard some of those symptoms can be to pin down. So, and we also know that stress can be a major trigger to take Graves' disease from the background if you have a genetic predisposition and to trigger it. So whether the stress of an infection or the stress of the vaccine or everything, the stress that everyone has been under over the last few years. So I think it's hard to tease out, does the vaccine have a rate of causing Graves' disease? So again, case reports, but no definitive link between the two.
Great. We have another Facebook Live question. I'm not entirely sure what this means, but I'll sort of direct this to you, Dr. Gigliotti. Can COVID mutate under radiation treatment if needed? So I'm wondering if the question is, does the virus have a chance to mutate with radioactive iodine treatment?
So I haven't seen too many people who have chosen radioactive iodine during the pandemic. So many people have been choosing anti-thyroid medications just because there's less utilization of resources, less time spent in the hospital. Not that radioactive iodine is all that difficult in terms of it being usually a single one-day treatment, depending on if a scan is done. But in general, I'm not aware of any data that radioactive iodine will cause COVID to mutate or change.
Thank you. Dr. Dream, can you talk a little bit about fatigue after thyroidectomy, where this comes from, and what avenues patients can pursue?
Yeah. So I think the most obvious is subclinical clinical hypothyroidism, so not being on enough Synthroid. So to get those labs and to adjust Synthroid dosing is the first place to start. I think if patients still continue to have fatigue, then sometimes we talk about doing LT3 and LT4 replacements, so supplementing with additional types of thyroid hormone. There's also some discussion about like the byproducts of thyroid hormone, like when it's made, T1, T2 are things that we don't have replacements for. And so we don't really know what those do because they're just byproducts along that process. So fatigue might be coming from that, and having some native thyroid for some patients might be really crucial. But there's really not very good studies to say if that's actually a mechanism or not. We just know that there's some people that feel this fatigue. And it's definitely something that we need to look into a lot more. But there's a lot of different avenues to start down before we kind of start speculating there.
Yeah, I have to agree. I think it's one of the most common things people will come back to the office talking about. I think it's way more nuanced than we give it credit. Dr. Gosnell, there was a recent paper that came out last year on racial disparities and complication rates, I think related to thyroid surgery in general. Do you have any information on what some of the underlying causes for this might be?
Thank you for that question. I think like many of the panelists and moderators and the audience, reading papers like this are, they're very sobering and very shocking. I still find that it very surprising, which I suppose I shouldn't be surprised, but one of the recent publications did look at about 6,000 patients and found statistically higher incidences of some of the more, not common, but some of the complications that we worry about with thyroid surgery for Graves' disease. And that's hypoparathyroidism or hypocalcemia and injury to the recurrent laryngeal nerve, as well as other complications. And those complications were higher in patients in essentially African-American patients. Now, I think just understanding that that exists is really important. And I think we've seen that among many other diagnoses. I think the reasons why are complex and likely multifactorial. There have been some suggestion that part of this may represent more advanced disease. Some of it may reflect differences in access to specialized surgeons. So there's been kind of publications and support in the literature that people that do this a lot tend to have lower complication rates. And if you don't have access to those surgeons, that might contribute to higher complication rates as well. And I think there are probably other reasons that some described and probably some that need more research in terms of structural racism and even individual racism. Although again, very kind of upsetting to think about that. But I think those are some of the things that I think that have been described.
Thank you so much.
Dr. Mchenry, can you maybe talk about what patients can expect to do to prepare for thyroid surgery, specifically relating to their Graves' disease?
Sure. We do some special things in patients with Graves' disease prior to operation. One of which is starting them on a potassium iodide solution. And this is, some surgeons use this, some surgeons don't. But it is the rationale for using potassium iodide prior to surgery is that that it reduces the vascularity of the thyroid gland, with the idea that it may make the operation easier and reduce blood loss. And typically we treat patients with potassium iodide for 10 days prior to the operation. The second thing that we do that's a little bit different than with all other patients who we do thyroidectomies on is we treat patients with, we start them on vitamin D. We start them on what we call recalcitriol or Rocaltrol. And we typically do that 3 days prior to their operation. Sometimes we'll add calcium, but the most important thing is starting them on Rocaltrol. And the rationale for this is that patients with Graves' disease have a higher propensity to develop hypocalcemia afterwards. And and the theory behind that is because their system is so revved up by their thyrotoxicosis, they can get some element of thyrotoxic osteodystrophy. They almost get like a sort of a bone hunger after surgery where their bone acts as a sump to take up calcium. So we, in preparation, anticipating that this potential drop in calcium, we start them on patients with Graves' disease on this calcitriol 3 days prior to surgery. Those are the most, I'd say, important differences in terms of things that we do for patients with Graves' disease, as opposed to somebody who we'd operate on, take their thyroid out for nodular thyroid disease or thyroid cancer.
Dr. Gigliotti, I was wondering if you might shed some insight into how you go about sort of deciding or choosing sort of the treatment options, because there are so many with respect to the treatment of Graves' disease. How do you sort of go about your algorithm when you meet someone with Graves to decide between radioactive iodine and a surgical intervention, or just medications?
So one of the themes in the American Thyroid Association guidelines for the management of hyperthyroidism is how important it is to engage patients and to ask about people's preferences and values, and to have that shared decision-making drive the decision. And the reason is that all three options, antithyroid drugs or definitive therapy with radioactive iodine or surgery, are all good options with pros and cons that have been very thoughtfully discussed by the panel so far. I think most of my patients choose antithyroid drugs because they like the idea of reversibility and titratability. And there is an upwards of a 30 to 40% remission chance after a year and a half of therapy or longer, which does seem to increase over time. And these medicines are very safe with a few rare side effects. And of course, some of the things that were mentioned earlier, like pregnancy or desire to become pregnant, these are things that really can dictate, because these medicines do have teratogenicity. They can have birth defects associated with them. So often the decision-making depends on how old the patient is, how severe the hyperthyroidism is, whether or not there's a large goiter. And in general, I would say, again, most people choose antithyroid drugs at least to start. And even with these other options, especially surgery, we'll often pre-treat depending on risk, because as people get older, there's a higher risk of an overly fast or abnormal heart rhythm from the hyperthyroidism, of bone loss and fracture, and a number of other complications. So we tend to pre-treat with the medicine anyways, and then stop it after surgery.
Can I add something?
Yeah, please.
Yeah, thank you.
Please.
And it's so great to think. I'm glad there's an endocrinologist on our panel, because it's so helpful, and we work together as a team so frequently. I was just going to mention, as a surgeon talking to patients, I get quite worried if I'm seeing them only a couple of months into the diagnosis, and I think it's always a good idea to kind of talk about the option, but I usually given that possibility for remission, I often will have the conversation, but then I'm happy to see them back, but I usually like them to have a little more time, unless there's something that's changed or different, or something that's kind of prompting that, or pushing us to the definitive therapy.
I agree with that. And the other thing is, like, if patients are on very low doses of methimazole, because sometimes we're just trading a pill for another pill. And if patients are really happy with where they're at, even it's like 2, 3 years, 5 years, 10 years later, I don't push them to have surgery in any way, shape, or form, because I think some people are happy with where they're at, and I can make things worse. Sometimes I can make them better, or I can keep them the same. And if someone's happy and I make them worse, then I don't think anybody's happy.
Right.
And we do have now long-term safety data on the antithyroid drugs, and know that most of the side effects, especially agranulocytosis, a critically low white blood cell count that increases risk of infection, most cases occur in the first 90 days after starting. So it's sort of, once you get through that initial time period, usually the risk of complications or side effects is low.
So we have another Facebook question that I think will stick with Dr. Gigliotti. Have there been any issues with any one particular vaccine maker to date as it relates to Graves' disease? I'm assuming that this is the COVID vaccines.
I have seen case reports from all of the vaccines that are currently out and approved of Graves' disease afterwards. But again, it's so hard to figure out causality and whether it was a coincidence or truly related to the vaccine. But one does not seem safer or less safe than others.
So I guess moving on, again, this is a surgeon heavy panel, so I'll take advantage of the expertise here and move on to another surgical question. Dr. Dream, we talked a little bit about sort of how one prepares the patient or patients for an operation in Graves' disease, but can you talk a little bit about how you prepare the patient with regards to informed consent? Sort of what are some of the things that patients should be aware of as potential risks related to the surgery, and what life will be like after surgery?
Yeah, I think those are great questions. So we always talk about risks of just technically of the operation, recurrent laryngeal nerve injury, which in the hands of a high volume surgeon is usually less than 1%. Hypoparathyroidism, which can actually in the first couple of weeks after surgery, so low parathyroid hormone level and low calcium levels can be upwards of 40%, depending on what study you read. So that's a very high number. But at a year is closer to 2 to 4%. So permanent hypoparathyroidism and people needing to be on calcium long-term is much lower than people needing in that immediate post-operative period. And it's because of what Dr. Mchenry was talking about, a lot of that bone turnover, you can have just some effect with your parathyroid levels. Hematoma rate, which again is usually less than 1%. And then depending on the surgeon, sometimes we use potassium iodide. I personally don't use it because I didn't train with it and I haven't really found a benefit to what the times that I have used it, but it's definitely something that people do and definitely very well accepted. What else? So the other thing I think that comes up a lot is the fatigue question, which we've kind of already discussed. And it's hard to tell who's going to have that chronic fatigue afterwards. The other thing that comes up often is weight loss and weight gain. And that I also think is a really hard question to answer because a lot of times patients are coming in and they've had kind of this high level of metabolism. A lot of people will gain weight after their Graves' thyroid comes out because that like superhuman metabolism is just not there anymore. So you just can't eat the way you were eating beforehand without gaining weight. You just become like me. But there's also people that are on really high doses of methimazole and they're gaining weight because they're hypothyroid functionally, and then they lose weight after their thyroid. And there's people that are like in a really good spot. You take their thyroid out and you get them on a really good dose of Synthroid and it doesn't change. So I always say it's like a third. And we don't really know until after surgery where you land. Those are kind of the big things I tend to talk about though.
I'd just like to make a comment about the surgery for Graves' disease too. Surgery for Graves' disease too, it can be more challenging. And although, in many series, the complications rate may not differ when you operate, when you compare it to patients who you operate on, say for thyroid cancer or nodular thyroid disease, but it is a technically more difficult operation. And it's because the vascularity of the thyroid gland, the gland is so vascular and it makes it more challenging. There's more bleeding and it makes it a tougher operation. And that, and I would comment, is something that really to take note of in patients with Graves' disease. And I think that's a really, it's important. We talked about, Dr. Gosnell talked about, sometimes why it is that in African Americans may have had higher complications to surgery, and it may be related to access to high volume surgeons. I think access to a high volume surgeon, if you're going to have a thyroidectomy for Graves' disease, is very important. And what do we mean by high volume surgeon? Well, there's data that says if you're doing you really should, greater than 60 or 60 thyroidectomies a year, that you'll see complication rates that are lower than those that are than low volume surgeons. So I think this is really a situation where a high volume surgeon is of benefit.
And we've got another Facebook question, Dr. Gosnell. There's some research saying drains after thyroidectomy may be counterproductive. And how often are we using drains now for thyroidectomy and Graves' disease? What sort of goes into your decision-making on whether or not to place a drain?
Yeah, thanks for that question. So I guess to answer in short, I very rarely leave drains. I'm sure that if you talk to different surgeons, people will have different thresholds for that. I think that it sounds like, intuitively it would maybe make sense if we're concerned about bleeding in the neck to have a drain to evacuate that. But unfortunately, usually the blood actually clots. It forms a clot that then can kind of push on your windpipe or your trachea. So they don't really work in the way that we would like them to. I generally don't place drains for the purpose of draining blood. Not often, but occasionally use them doing neck dissections when I'm worried about serous fluid or lymphatic fluid. I honestly can't remember the last time I put a drain in after a thyroidectomy for Graves' disease, but maybe some of the other panelists would like to weigh in also.
I agree with that. I think I generally, when I choose to use a drain, it's because it's a very large thyroid and I'm more worried about fluid buildup and not blood. Bleeding is not generally treated by drains. It's a really good meticulous operative technique that prevents the blood in the first place. And it drains clot off. So I generally don't use them in Graves' disease. It's more goiters that we end up using the drains for, and it's even then infrequent.
So I agree. I never use a drain, and there's there is good data, looking at randomized controlled data that shows that drains don't alter the incidence of significant hematoma. So I don't use drains.
I was also going to add that these are the types of questions that are really good to ask. The whole question about the consent, I absolutely agree with everything that was said. The more, as surgeons, the more we understand about the process of informed consent, for me, the more I understand it can be inadequate. Sometimes people hear these numbers and it seems very low, or it's hard to really truly understand what the potential problems are. But things like this, like drains and volume, those are all really important to talk about. And especially in an operation like this for Graves' disease, where it's an option, that's when you really want to kind of have multiple conversations over time with your surgeon, your endocrinologist, family, friends, not necessarily the internet, but just kind of think through things, going to people that you trust or sites that you trust, and really spending some time understanding what's important to you, and what are the priorities of your healthcare team, and making sure that things match up.
You should put in a plug for the AAES's website's physician finder in terms of finding devoted and skilled thyroid surgeons.
Very good. Thank you for that. To Dr. Gigliotti, I was curious if you could shed some light on what's new in Graves' disease treatment with respect to other treatment modalities that might be out there, biologics and things like that. Can you comment on what's new in the treatment of Graves' disease?
Absolutely. So as of right now, Antithyroid drugs, radioactive iodine, and surgery are still considered the definitive therapies, and everything else is considered experimental. There's some new peptide-based therapies that are looking at trying to change the underlying autoimmunity, because if you think about it, Graves' disease being an autoimmune disease where the thyroid is being short-wired or stimulated, all of our medicines, antithyroid drugs, inhibit the thyroid, and surgery and radioactive iodine destroy the thyroid. So they're somewhat inelegant solutions. Whereas most people think of autoimmune disease of getting steroids and trying to treat the underlying autoimmune disease by using these different biologic agents and whatnot. So I won't really go into the details of these various therapies because they're still so hot off the press and being studied, but there are a number in the pipeline. But one of the critical things is that they would need to be shown to be superior or at least equivalent to the current therapies we have, which are very effective for many people. But I'm particularly excited about some of these TSH receptor directed therapies to try to address the underlying autoimmunity.
So I guess I'll ask maybe the surgeons on the panel. I've recently come across very difficult access to potassium iodide. So I've kind of gone away from using it. I've used it selectively in patients that would have the larger Graves' goiters to try to reduce the vascularity. Are you all having access issues, or is it just a Hawaii thing?
So that was the original reason why I didn't train with it, is because it was tough to get for patients. But you can get it on Amazon, from what I understand. Like you can type in Lugol's, because I know a lot of people that use it, they have difficulty getting it through their pharmacy. So a lot of people are directing their patients to like online pharmacies or Amazon to not like, I don't work for Amazon or anything, but I know you can get it.
It is a challenge. I usually, when discussing it with patients, mention that this is not something you can kind of get that, the week before the operation. If I do think it's important in that particular patient to use, we start that preparation well before, and it can be challenging. So in San Francisco Bay Area, there's like one compounding pharmacy. And so if people are having trouble, then we do have a very reliable source. But again, it takes, kind of that planning and discussion and that review. And I would also mention that we sometimes it can be really helpful for patients that can't take the antithyroid medications, like they've had a pretty serious side effect. And so then the Lugol's or the SSKI can be a really important way to kind of prepare them for surgery in the absence of those other medications.
Yeah, Dr. Woodruff, we've had the same issue. There is some difficulty with obtaining the potassium iodide. We're lucky because our hospital pharmacy is the one pharmacy that has it. So that the pharmacies that at our satellites don't have it. So I tell patients, you're going to have this filled here at our hospital. The one thing that is a little disturbing to me is we can talk about disparities, but patients with Medicaid, that's not covered under their insurance. So they cannot get the potassium iodide. If they want that, they have to pay for that themselves. And that's, that's a significant expense for those group of patients that they can't afford that. So we have other social programs that we can help these patients pay for, but some of them don't get it. And obviously I'll do the surgery without them on potassium iodide, but that's another issue that we've run into, is that it's not being covered under certain insurance plans, particularly Medicaid.
Dr. Gigliotti, I wonder if you could tell us, the endpoint of any of these treatments used for Graves' disease is to ensure that it never happens again. Can you comment on remission rates for these different treatment options available?
Sure. So for antithyroid drugs, we often quote the remission rate as being somewhere between 30 and 40%, but there's a lot of predictors of remission, and those are particularly helpful to look at when working with your doctor to ask, what is my chance of going into remission? Because we know that men have a little lower chance compared to women. We know that very large goiters, severe hyperthyroidism, high T3 levels, all of these are associated with somewhat lower rates of remission, and developing a sort of an individualized plan and knowing what the information, how it can be applied to your specific case is really important. We know that, so if remission is 30 to 40% at a year and a half, or 2 years, it does increase over time and can be as high as 70% looking at 5 to 10 years beyond therapy. For radioactive iodine, since the goal is to destroy the thyroid, actually it's fairly rare for people to need more than one treatment. I'd say definitely less than 10%. And probably even less than 5%. And that's because in the old days, we used to give radioactive iodine, trying to give just the right enough to kill some of the thyroid and try to help people become euthyroid or have normal levels. But the problem is Graves is stimulatory. The antibody turns on the thyroid, it makes it grow, so the hyperthyroidism always comes back. So the goal with radioactive iodine is, again, it's somewhat inelegant, but to try to kill off the thyroid, to trade hyper for hypo, knowing that hypothyroid hormone is an exact duplicate of the body's natural thyroid hormone and is more of a hormone replacement therapy than a medication.
Great, thank you.
I've run out of questions.
I know.
I guess I had another patient very recently that with Graves' disease that had agranulocytosis to methimazole. So she was unable to take that. She kind of did okay off all medications for about a year, and then had recurrent Graves' disease that was mildly symptomatic, but her free T4 was one of the highest I've seen. So, I guess maybe for the surgeons, what sort of concerns do you have with that particular patient, knowing that we can't use the methimazole? I think she even had a reaction to PTU, so they had tried both of the antithyroid medications and couldn't use that. So maybe talk about, if you've had a similar experience, what you've done to get the patient to surgery.
Yeah, so I'll start. Those patients are, and we didn't talk about this before. One of the other things about when you're operating on patients with Graves' disease is you're optimally like to have their free T4 and free T3 levels in the normal range prior to operating on them. Their TSH level, that may delay, that doesn't necessarily have to be in the normal range, but you'd like to have their free T4 and free T3 levels in the normal range. And the rationale is because surgery is a stress, and that can precipitate a state of thyroid storm. And these are patients that can get high fever in the operating room. They can get tachycardia. They can get tachyarrhythmias, atrial fibrillation, even ventricular arrhythmias. So that is bothersome. I share your concern when you can't get the patient's free T4, free T3 level in the normal range using an antithyroid drug. In that situation, we use a beta blocker. We do the surgery under beta blockade and make sure that we have the patient under adequate beta blockade. And for the audience, we're trying to control the heart rate with a medication. And that's really the key. And so the caveat is we would do it under beta blockade.
Such an important point. You know, most of the symptoms of hyperthyroidism, regardless of the cause, are adrenaline type symptoms because of that being downstream of thyroid hormone. So using an adrenaline blocker like a beta blocker is a very helpful treatment to help control symptoms if you can't use antithyroid drugs or if you're waiting for them to kick in.
Also, I've had a similar situation where the patient, we put them on steroid to kind of get them stabilized and under control, in addition to like a beta blocker. And then in that case, potassium iodine, because that also helps for sure in this case too. So kind of all of the adjuncts that you would use to help someone in thyroid storm, but understanding that we're doing it because we don't have thyroid hormone, and that's all going to be like of a limited lifespan. So we have to do that with a surgery date in mind. Yeah.
Very good. We have another question here. Dr. Gosnell, is it feasible? Why can't we do thyroid transplants? Fascinating.
I saw that question. What a great idea.
I think it is fascinating.
It is a fascinating, and of course, it makes me think of parathyroids. I'm not stalling, but parathyroids are amazing because they have this tremendous ability to, basically be able to develop a new blood supply if they're prepared and kind of minced into little pieces, and we can transplant them. You can put them in muscle, you can put them under the skin, you can inject them into muscle and do lots of really cool things. I think the question is, number one, can you get thyroid cells to survive? But also, how do you then access them? So in Graves' disease, we wouldn't want to just be able to transplant them. We would also need to be able to access them if we needed to remove them. So I don't know. We haven't. I absolutely agree with a comment before. There are so many things that we do now that do seem inelegant, and someday we'll look back and think, wow, we took it out. How interesting. But we're not there yet. And I don't know if anyone else has any more up to date. I work a lot with auto transplants with parathyroid, but I don't know if there are a lot of ongoing studies with thyroid transplants.
I think that's a really hard thing to justify doing too. So with the regulating bodies with transplant, if you're transplanting an organ that's not yours, you have to be on immunosuppression. And so knowing that we have a really good thyroid hormone replacement, to then justify putting someone on immunosuppression, it's really hard to get around the governing bodies that would say that that's not really ethical to put someone in an immunosuppressed state when we can put you on thyroid hormone replacement.
They are working with very local forms of immunosuppression,
right?
Being kind of like nanotechnology or even topical forms, such that if you did a transplant, you could, put this topical immunosuppressive agent. I think all of this is kind of right on the edge, but people are working on it. We do have a recombinant, like a form of PTH, of parathyroid hormone, for folks that don't have enough of their own parathyroid glands, and it's very expensive and it's only using injections. So that's why we're really working on trying to figure out a way to transplant parathyroids in different individuals without having to put them on those, kind of the all over immunosuppressant regimen. So I think these things are coming.
Dr. Mchenry, we have another Facebook question. Can you talk about, I guess, the recovery after thyroidectomy, how soon someone can get back to work and to their normal activities?
Sure. Now this is all, I'm just going to give you my personal, how I do it. It's not really based on firm data, but I'll tell you how. I typically recommend that patients take 1 to 2 weeks off of work, and it's really dependent on them. I recommend that they, I tell them to avoid driving for a week, just because that their neck incision may affect their ability to turn in the car. And I tell them, for a period of time for 2 to 4 weeks after surgery to avoid any major heavy lifting. That's a soft restriction, but that's something that I do. Otherwise, after 2 weeks, I let them go back to starting to exercise and do activity. I, have them, walking, walking on a treadmill. And so they're back to really their, regular activity after about 2 weeks from surgery. And that's pretty much how I manage my patients.
Yeah, I do pretty much the same thing, 1 to 2 weeks, and then kind of gradually get back into your normal stuff. Yeah.
I would agree. I often will tell people, because people will hear 1 to 2 weeks and try to go back after 1 week. And especially for Graves' disease, the word that many patients tell me is they just feel crummy. If you try to go back that second week, you're just, your body's working hard trying to heal. So I think it's just too much. So I think having that second week can be a really nice time just to, commit to healing, and then it makes the whole recovery more smooth. For people that try to go back too early, sometimes it just prolongs that.
I agree with all of that. Nothing to add.
All right, well, as we approach sort of the top of the hour, we would like to thank all of our viewers and supporters for joining us this evening. A special thank you to our expert panel for taking time out of your busy schedules to join us in answering these questions and discussing Graves' disease and all the treatments available. We want to thank the GDATF again for their support.
As a reminder, this session was recorded and will be available on the AAES Facebook page and on the AAES YouTube channel. For more helpful information for patients, please be sure to visit the AAES patient education website at www.collectedmed.com/AAES patient education.
Thank you, everyone.
Thank you.
Thank you, guys. It's great discussion.
Nice job, moderators.
Thanks. Sorry, I ran out of questions.
No, you did such a nice
What do I
job.
ask now?
No, you did such a nice job. Yeah.
Well, thank you all for
Yeah.
joining us. We really appreciate it.
Ben, it's nice to meet you. We didn't get
Yeah,
Privilege.
nice to meet you.
Yeah.
Nice
The
to
privilege
meet you.
is mine. I
Yeah,
often say that
wonderful.
an endocrinologist cannot do their job without access to an excellent thyroid surgeon. At U of R, we have Jacob Moallem, who's just wonderful and has been a mentor to me. And I know I couldn't practice without the multidisciplinary setting. So thank you for doing all that you do and for taking such good care of our mutual patients.
Great. Well, enjoy the rain. I'm sure you guys are gonna really want that.
And the
We'll enjoy
snow.
it.
We'll enjoy the snow.
That's
Exactly.
right. Happy holidays, everybody.
Yeah, have a good
to see
holiday,
you.
everybody.
Happy
I think
holidays.
Yeah.
nobody's
Happy
given us any
holidays.
instruction, but I think we can go.
Yes, that's a wrap. You all
All
did
right,
wonderful.
bye,
Thank you
guys.
so much.
All right, good night,
Bye.
everybody.
Bye.
Bye. Thank you.
Thank you.